Facebook. I am just trying to go live on Instagram. For some reason, it doesn't want to let me go live. Hello, everybody, and welcome to the PT on Ice Daily Show. Let me just try and get live on Instagram. Give me 2 seconds. All right, let's see. Checking connection. Here we go. Woohoo! I almost made the same mistake I did on Monday. All right, reintroduction. Hello, everybody, and welcome to the PT on Ice Daily Show. My name is Christina Previtt. I am one of 2 lead faculty for clinical management, modern management of the older adult. I am getting my words mixed up as I fumble to try and get the live feeds on. We have 3 courses in our geriatrics division. We have Modern Management of the Older Adult Essential Foundations, which just started last week. We have Advanced Concepts for individuals who have taken our 8-week online version. And we have our live course where we have Alex Germano and Dustin, who are going to be in Delaware this weekend teaching our live version of the course. And when you are on the live course, you can challenge for CERT MMOA. So if you have taken all 3 courses and have passed the skills check, you can become certified in modern management of the older adults, which is really exciting. And we've had more and more people going through that certification, which is really fun. If you guys are interested in learning a little bit more about some of the research, like some of the papers I'm going to talk about today, they're going to be in our MMOA digest. This is a bi-weekly email that we send out that is Jerry specific and talks about all of the upcoming literature in different areas of geriatric practice. So if you guys are interested in jumping on to that, I encourage you to do so because we geek out a lot about stuff going on in geriatrics, and so we would love to have you guys on that email list. Okay, so earlier this week, I posted a reel about one of my clients, and I ended up getting a lot of questions about it, which is really fun. He's in his early 70s. He had a triple bypass done in early 2013, and then went in for a procedure and was given vancomycin, ended up having a massive allergic reaction to it. And because of that, went in and had multiple, they called it cardiac events. So he had about 6 heart attacks in the span of a short amount of time, which threw him into congestive heart failure. And he has been stable ever since and been being monitored by a cardiologist and monitored by his family physician. But he was coming in to see me in the clinic for a ankle/knee issue. So he had quite significant lower extremity arthritis, had a peroneal surgery on his ankle. He had his knee replaced that same side about a year ago. And we were able to clear the musculoskeletal pain relatively quickly. But what I noticed very early on is that he was very deconditioned from a cardiovascular perspective. And a lot of that was, I think there was a lot of fear of movement. And if you've worked in cardiac rehab or if you've worked in geriatrics for a while, some of these restrictions that people have placed on them after an early cardiovascular event that are never discharged can create a cycle of deconditioning that occurs because people think that they can't lift or move even as they get further and further away from a cardiovascular event. And the problem with that is that the heart is a muscle, which means that it responds to progressive overload and stimuli. And that means that we need to be trying to push our clients slightly and in a progressive way in order for them to get their heart stronger. And this is an area of practice that I think that PTs are not capitalizing in our role in this. And I think that there's definitely a niche for us. We have some publicly funded or hospital affiliated cardiac rehab programs for acute episodes of cardiovascular incident. And that can be atrial fib, it can be CHF, it can be any cardiopulmonary condition. But the transition into exercise in the community is usually fairly poor. They try their hardest and they have specific ways that they ease people off cardiac rehab, but we are definitely seeing more and more people in our community, or if you are a home health clinician that you are seeing at home, that have pretty significant cardiovascular compromise and aren't thinking that they need to rehab that, and are essentially just slowly deconditioning until another subsequent event happens, or until their meds increase and now they're on a cluster of cardiovascular meds with diuretics and Lasix and all these types of things that we tend to see in our med review. And so one method, especially when we have a short amount of time, for us to be trying to optimize our rehab is to use high intensity interval training. And so you know that the fitness athlete crew had coined the term REMOM, the rehab every minute on the minute, which is a variation of a high intensity interval training that is using cardiovascular training as well as strength training or functional movements. But it might be something that, and we have heard that some people have been a bit tentative about putting in something like that into their exercise program because of the cardiac status of a lot of the clients that they're seeing. And so last year, there was a physician named Yashan Dunn. I don't know if I'm pronouncing that correctly, but him and his colleagues did a really nice review that was synthesizing the use of high intensity interval training specifically for cardiac rehabilitation in older adults, and used it to try and give us some pretty specific guidelines, which I really, really love, because high intensity interval training is conventionally thought of as something that is only done with athletes, which I understand why we have that idea, except that it doesn't necessarily always have to be the case. And when we talk about this in our MMOA course, we always talk about the fact that intensity is relative, right? We know that what is going to be considered high intensity for my 15-year-old athlete is not going to be the same as my 85-year-old. But what we're looking at is relative intensity. And so when we're trying to prescribe cardiac rehab, the first thing that we need to know is what are the measures that we are going to be looking at in order for us to be able to prescribe this appropriately. And so what they had done was they had talked about objective and subjective measures of intensity. And so traditionally in cardiac rehab, and what has the strongest literature to support it, is the use of a peak heart rate. This is oftentimes done off of a stress test, an exercise stress test, where we get certain parameters and numbers that allow us to be able to see the capacity of the heart and then take percentages of that to do a progressive overload. If you have that information available to you, that is amazing. I would say that a good majority of my clinicians that are seeing in the community don't have that. And then so they said that we have some of those objective measures, but we have some subjective measures as well. And the two that they talked about using the most is the Borg scale, the RPE scale, rate of perceived exertion, and a dyspnea scale. And talking between a scale between 1 and 10, talking about how out of breath a person is following a specific interval, and that can give us an idea of how much time they're going to need to recover from that in order for them to repeat that interval. So the literature is showing that high intensity intervals should be done at an exercise intensity between 85 and 95% of peak heart rate, which would be an RPE between 15 and 17 on the 20-point scale. This would be probably between 7 and 8.5 on the 10 scale. And low intensity intervals should be done at 50 to 75% of peak heart rate with an RPE between 12 and 14 on the 20-point scale, which would be kind of between like a 5 out of 10. And this is going also, then the duration of these intervals is going to depend on the patient's level of conditioning or deconditioning, symptomology, disease severity, and comorbidity. So I thought that was really helpful to have, this is where we're hitting for the high intensity intervals, this is where we're trying to hit for the low intensity intervals, and then we're going to use our clinical reasoning to try and create more of a prescription. And so the next piece is, are we doing short intervals, medium intervals, or long intervals? And that is relating to the high intensity part, and then what we're going to do in terms of the amount of recovery we need in between exercise bouts in order for your client to be able to reproduce it. What is traditionally prescribed when we're thinking about athletic training is the demand of the sport. So if you have a client who is a sprinter, you're probably going to do more short intervals. If you have somebody who's an endurance runner, you're probably going to be doing longer intervals. But what is the case for older adults? The literature is kind of all over the place. And so the reason why, so the way that I would like to conceptualize it and the way that these physicians conceptualized it in their paper is I want you to think about your client's day. If you have a client who is significantly deconditioned, they're probably doing high intensity interval training all day to complete their ADLs. And this was such a change in my mentality because I had never thought about it that way. If I have a client who is in 1 rep max living and is getting up from a toilet and it takes them 10 or 15 seconds to do that because they're having such a difficult time navigating around their bathroom, they just did a 15-second interval and they're probably at a high intensity. Their heart rate has probably spiked up. They're working at a high percent of their max volume contraction when it comes to their musculoskeletal capacity. And then they're going to have to recover from that. And if they have to then walk down the hallway to get back to their chair, they may actually be in a state of high stress, high peak heart rate in order to just complete that task throughout their day. And so if we have clients who are like that, and I'm sure my geriatric PTs who are listening to this are shaking their head saying like, yes, I've had a lot of clients like that, then we definitely can see how this protocol might be useful. So some intervals, I'm going to just give you a couple of examples of protocols that have some literature to support them. Long interval HIIT training that's been used for older patients with cardiovascular disease has included 4 sets of high intensity intervals that have lasted 4 minutes, and the low intensity intervals are 3 minutes. So in this case, they're working at a higher intensity for longer. So if we're thinking that you're going between 85 and 95% of your peak heart rate, if you're in a longer interval, you're going to be at the lower end of that. So probably trying to hit 85% of max heart rate or an RPE of 15 out of 20 on the 20-point Borg scale. And then 3 sets of lower intensity intervals that are 3 seconds long. An example of a medium intensity interval that's been used for older adults with cardiovascular disease has been 8 sets of 2 minutes of high intensity training interspersed with 2 minutes of low intensity training. So now this is starting to switch, where in the long intervals, you're working for longer periods of time at a higher intensity, shorter period of time for low intensity. As you go into the medium intensity intervals, you're seeing equal work to rest ratios. And then for some of the short intervals, you've had 10 times 1 minute high intensity intervals interspersed with 2 minutes of low intensity rest in between. And this was validated in individuals with heart failure with a reduced ejection fraction. And so all of these things, all of these intervals have been validated in individuals with cardiovascular compromise. They've all been working in an older adult population over 65 and have shown to see increases in peak VO2, which is going to be a marker of cardiovascular capacity, and in quality of life, which is a functional measure that we as PTs are oftentimes really worried about. And so some of that is really wonderful. And so when we look at some of the physiological mechanisms and some of the benefits of high intensity interval training with our older adults, we have seen so many really wonderful benefits. We've seen significant improvements in respiratory muscle function in older adults with heart failure. We have seen that the pulmonary system is now able to take up more oxygen for working skeletal muscle, which is going to be important for our outcomes if we're looking at our trying to build functional resiliency in our older adults. We have seen that high intensity interval training has been able to increase peak cardio output, which is really wonderful. We've also seen some musculoskeletal benefits where after 6 weeks of high intensity short interval training, we saw an increase in the amount of type 1 and type 2 fibers, increased capillary density in the vastus lateralis muscle, and increased protein expression for protein synthesis in those lower extremity muscles that are being utilized in these protocols. So we're also starting to see some benefit in terms of muscular strength and capacity. So I know what you guys are thinking. Is this safe? Is this safe? Because that's the number one question, right? And they address this as well. And I'm going to I'll post the study, and I'm going to be commenting about this study as well on the ICE social media pages. So it's going to be there. But they had two really large randomized controlled trials that looked at, what's the number? 4,846 cardiac rehab patients with cardiovascular disease that were average age of 58. So the standard deviation was about 10. So we're seeing between 48 and 68, which unfortunately is I feel so young. It's a young age for us to be having our first cardiovascular event, but tends to be the case. And so in that large study of almost 5,000 people, they had one fatal cardiac arrest during the medium intensity cardiac rehab and two non-fatal cardiac arrests during HIIT. So there was no fatal injuries, and the difference between the groups was very low, and incidence of that was very low. And then rate of complications for patient exercise hours was one cardiovascular complication per 1,290,456 hours of medium intensity and one per 23,000 hours of HIIT. And then there was another study that showed that there was no difference in total number of serious adverse events in another protocol. So basically what they said is that you have to make sure that you are monitoring that prescribing medium intensity or high intensity exercise in a cardio rehab setting is not without its risks, but the risk benefit ratios here are going to be significant and important to think about, because we need these people to be strong, and we need them to have the reserve in order for them to complete their ADLs and IDLs. All right, I hope you all found that helpful. I think about this a lot with my clients in terms of how do I build the bike to get them active in different capacities and different ways that they like over the course of their lifespan, so that they may be seeing me for knee pain, but they are coming out a stronger, more resilient human in multiple facets of health, kind of building on what Julie and Danny had talked about in our Vice lecture last night, which was so amazing. So kind of building on that, how can we really set our clients up for long-term success no matter what setting we are seeing them in? I will post that study below. We actually go into cardio rehab in our advanced concept course. So if you've taken Essential Foundations and want to geek out about all things cardiac rehab, I encourage you to take our next advanced concepts course. It starts in January. Otherwise, I hope you all are having a wonderful, wonderful Wednesday, and we will see you all soon.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review, and be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.